So, for many patients, Medicare beneficiaries, ACOs sort of operate in the background. It's sort of a relationship between the ACO and the physicians. Is that true with you folks, or have you, are people aware that they are being treated in a ACO network that is designed to improve the quality of care and control costs?
Yeah, as specific to NextGen, there are patient outreaches that will happen, each year, and so that is communicated. I think, the important thing is that Southwestern Health Resources is an ACO that is sponsored by Texas Health Resources and UT Southwestern, and those, what we'll call parent brands, if you will. Those are really where the majority of the caregiving occurs, at a parental level and under those brands and banners. We also have, a significant community physician footprint as well, right? So we have well over 550 primary care physicians that are all community physicians that are part of this clinically integrated network. We have about 750, actually it's probably closer to 900 community specialists today that are in our physician network as well. So when you add it all up, we have about 4,400 physicians in the clinically integrated network and over 5,200 providers. So it is, we don't market ourselves at Southwestern Health Resources as we are clearly the ACO and kind of the intel inside that's supporting all of the clinically integrated network. But our drive hasn't been to be most patient facing. But having said that, we do on behalf of that network in very meaningful ways. And I think COVID is a great example of this, where, we have provided an extensive amount of kind of marketing material as we've identified opportunities. We've seen patients dying at home, in kind of alarming numbers. And, when you have data on hundreds of thousands of patients, 700,000 under the ACO's care models, you're able to determine, that this is a really at-risk population. And so how can we come alongside those practices with care coordination support and the resources of Southwestern Health Resources to help them along. And so that's really led to a number of fantastic kind of developments in spite of COVID and due in large part. So we provide care packages to all COVID patients to make sure that, when they're back home, they've got a great start and on their recovery. We've identified certain zip codes where there is just a disproportionate number of cases, and so lots of education that's then poured into to those areas, and then of course, like I said, populations where they've got conditions where people are dying at home and people are scared to come in some instances, and so we've tried to make sure we focus education in those areas, and so it's not all in service of SWHR, it's in service of our patients and our provider network.
Right. So just to put this in a nutshell, you haven't sort of gone full guns in some sort of branding effort, that you are still, like many ACOs, sort of, as I say, as far as the beneficiary is concerned, I know there are some outreach letters, but you're still sort of primarily working in the background. Is that a fair characterization?
I think that's a fair characterization.
As far as the beneficiary is concerned.
I think that's right. I mean, I think they affiliate most closely with their physician and their, so, and whether that's Texas Health Resources physician group, Texas Health Resources facilities, because they've received a lot of care. They're UT Southwestern faculty physician or university hospital clinic. So there are, those are what I would say that they most align with. And of course, whether it's their primary care physicians on an employee or one of our community affiliates. I think if you ask almost any patient, I mean, it is their physician relationship that they first think of before all else.
So in describing your success, you emphasize clinical integration and the sharing of data, but there's a set of rules that, or loosening of rules in some respects, that apply to next generation ACOs that don't apply to other sort of ACOs. Have any of those rules been particularly instrumental in your quality and financial success? And do you want to see any changes in the program that would either build on those rules or maybe add a couple of, tweak the program a little bit? Just wondering whether there's any, if not secret sauce here, just key levers that make the program work for Southwestern Health Resources.
Well, I guess what I would say, and it's really not a big difference between MSSP and NextGen. I don't think. I mean, from the beginning, CMS has been a really an excellent partner in terms of sharing data and their level of transparency in working with our ACO, and I know all other ACOs. And so, I don't know that there's necessarily a silver bullet or secret sauce, as you say, but I can tell you that if you are able and have set yourself up to be able to absorb the significant data that they provide and have the tools then to turn that into useful information for your individual physicians, right down to the individual physician level, and you do so routinely, because I think we have to keep in mind, at the end of the day, a lot of this utilization per thousand data and risk adjusted this is a relatively new language, if you will, for a lot of physician practices who have been in fee for service for most of their entire careers. And so a lot of what we do is take the information that has been provided by CMS, CMMI, and translated that into very useful, actionable information for those providers and shared it with them routinely, and then kind of get them together so that they can think through strategies and how best to care for, populations rather than simply just their panel. And so I think that's one of the keys to our success is that we've done that and focused on that across the care continuum. It's one thing to be in an ACO and kind of be a single specialty ACO, and there's plenty of opportunities within that model. What our approach has been, though, is to look at this as comprehensively as possible, because we know half, 2/3 of the spend may be on the acute care side, right? And so we have to make sure that in those transitions of care, we're just really well orchestrated. And so we've spent a significant amount of time trying to take that data, understand where the kind of the pinch points are, or the exposures may be in that process, and try to make sure we kind of gird ourselves up in those areas to have success. So that's really how we've used the data, Peter. And I think we've also are just recently formally creating, in fact, a med econ department that is going to take what we've already amassed and really apply some very rigorous rules for how we assess each one of those opportunities that will then kind of carry on to a review process from a clinical and network perspective in terms of, okay, well, how do we really take that information, create actionable kind of next steps, and make sure that we can cascade that across the clinically integrated network so that we can align all kind of incentives and around executing on that. And so to that end, we've embarked on a journey to create our organization into an HRO, or a high reliability organization. And that is simply said a systemic approach to make sure that we have a rigorous review to kind of weed out any potential or likely failure points, if you will, within the broad process. And so, all that's originates and starts with, having great data. And I would say that, among all of our payers, and we have great payer relationships, and CMS is right up there in terms of their willingness and ability to share that data routinely.
So I believe it was last week, CMS announced that it was going to extend next generation program. I believe it was supposed to end maybe at the end of this year.
Yes. Yeah, that's right.
So assume that your corks popped at your company, and that this was you took this as very good news.
We did. We were reviewing MSSP direct contracting as potential replacements. And of course, before the announcement, weeks before the announcement on the next gen extension, we were informed that MSSP was not going to be an option. And so at which point, we began looking at direct contracting very closely or closer, thinking that may be our only option unless they extended next gen. And so, no, I think we were pleased that CMMI decided to extend next gen. I think it was the right thing to do, given the timing and particularly the complicating factors associated with COVID that really kind of overshadow all of this. So I think it was good. It's been an excellent program. I think we clearly have a lot invested in infrastructure and design. We know how it works, et cetera. So rather than change to a new kind of a direct contracting model where there are a lot more unknowns still as they're developing some of the final details there, we did welcome the news that we would be extending next gen for another year.
So you were you were ready to take the leap into direct contracting before next gen was extended?
We were assessing whether that would be a prudent move for the ACO, but we're fully committed to value-based care and working with CMS on these programs, and they've got a tough task, to design programs that meet the needs of a very disparate set of regions around the country, and to kind of create a model that can be fair and satisfy everybody is tough. And so, we were assessing direct contracting, like I said, just like MSSP. And it's a little, I would say we couldn't answer today what we would have done had we completed the review on direct contracting and next gen wasn't an option, but I was certainly glad next gen was an option.
So I took a quick look at the 2018 performance year results, and I'm working from memory, but I think I saw that you had shared savings of 36 million, maybe roughly 79,000 beneficiaries. Mm-hmm. What is 2019 looking like?
Yeah, so we've been growing pretty extensively as an ACO. We continue to add community primary care physicians and employed PCPs each year. So our membership in 19 grew to a little over 100,000. You start the year out with the highest number, and then based on decedent rate and various things that aren't factored in, it generally backs off. So and we feel like a really good 2019 as well. We don't have final results that are unembargoed from CMS that we could share, but we feel like we've got a very systemic approach to how we manage utilization and quality and care coordination within the clinically integrated network. So based on preliminary results, we feel like we're going to have another excellent outcome in 2019.
And the effect of COVID on ACOs and next generation ACOs, I've heard an argument that you're probably familiar with, that actually COVID-19 and the effect that it's had on providers that are still dependent on fee for service, when they've seen their number of patients and their revenues drop dramatically, that this might actually hasten the move into value-based contracts and more capitated type arrangements. Do you see it that way? And do you see, how's COVID-19 affected your ACO?
Very much the same way, I think, as a lot of other ACOs. We've focused and really pivoted as soon as this started breaking to having weekly meetings with kind of an all hands on deck with the physician network, where we began sharing the latest clinical information there was to share and statistics on COVID, as well as how to pivot from, as you say, in office, face to face. We did a survey of the network, and less than 2% were actually doing virtual care. Within a period of about 10 days to 2 weeks, that just flipped. Virtually everybody had pivoted to virtual care. So that's not unique to us, but we provided a significant amount of support for our network during that transition. And so it's been, that's been kind of a positive outcome, I would say, in learning, really hastening the move to virtual care, at least getting that familiarity with it. And then, it remains to be seen how we weave that into the care model of the future. But certainly virtual care is not going anywhere. I think it has proven itself a great tool within the broader care model. So, I think at the end of the day, we're gonna benefit from this. But as it pertains to COVID and its overall impact to the ACO, I think the jury's still out a little bit. Generally speaking, I feel like the reduced utilization that's occurred during that time frame is going to offset the increased expenditures on those members that did contract COVID. And so that, but that's early, and we'll see. I don't know, Jim, if you have other thoughts on the question.
No, COVID, certainly there's a lot of uncertainty around pre and post COVID. But as Danny referenced, it has been we have seen a decrease in the elective procedures. And so in Danny working with the network and facilitating the virtual medicine or telehealth has really been a significant impact on the network, as well as still continuing the care of our participants or members.